Hey guys, what's up? It's Stephanie. Welcome back to my channel. So in the video today, I'm going to be discussing my 8th month in a PA residency / fellowship in critical care medicine. Hopefully this video is helpful for you, especially for those of you who are wanting to do a residency and or fellowship. The name is interchangeable depending on what program you apply to. Regardless, it's the same thing. So hopefully this video is helpful for those of you who are wanting to apply to any of these as a PA graduate. I highly recommend them. I am biased though because I am currently in one, but I feel that the knowledge that I've obtained since the first day of the residency until now is just abundant. I feel more comfortable with procedures. I feel more comfortable treating ICU and critical care patients, and I'm able to actively triage a patient that's actively dying in front of me versus a patient that is not. That's something that definitely takes time, but the fact that I've seen everything these past few months has really prepared me as a provider, so I highly recommend them. So just real quick about me, I'm currently a physician assistant. I graduated in December of 2020 and I applied to a critical care medicine physician assistant residency. I'm currently in my 8th month and the rotations I've completed have been the following. Surgical trauma was month 1. Second month was neurotrauma. So neurotrauma, a lot of these patients that we see are spinal cord injuries, any type of head injury, traumatic brain injury. Third rotation was neurovascular ICU, just like it sounds, neurovascular, any type of strokes, any type of subdural head bleeds, epidural head bleeds. We also see any type of paralysis like Guillain-Barré syndrome, and then post-surgical patients from neurosurgery that have removals of pinealomas, for example. The 4th month I did it in surgical ICU. We saw a lot of thoracic patients there, so any patient that has any type of esophageal cancer, post-esophageal resection, any type of GI surgery, so your Roux-en-Y, your gastric bypasses, etc. And then my 5th month was in the cardiothoracic ICU. Most of these patients that we saw, like it sounds, were cardiac patients, so post-CABG patients, patients that had heart transplants, lung transplants, patients that had valve repairs, mitral valve repairs, for example, aortic valve repairs, and then also any just patient that was in cardiogenic shock. Those were the majority of the patients that we saw. And then my 6th month was in the MICU, medical ICU. Unfortunately, when I did that rotation during that time, the majority of the patients, if not all, were COVID-19 patients, so they were patient in acute ARDS. So I get really comfortable with the ventilator, making ventilator settings, especially in your ARDS patients, just treating ARDS patients in general. And then my 7th month was in the transplant ICU, just like it sounds, a lot of post-transplant patients. I got comfortable with treating liver patients that were post-transplant, also your cirrhotic patients, your GI bleeds, whether it's upper or lower GI bleeds that were actively hemorrhaging, kidney transplants, pancreas transplants, small bowel transplants. And then now I am back in the surgical trauma ICU, which was my 1st month. So they made me rotate again through this rotation because I'm going to be working in the neuro ICU. And surgical trauma, we get a lot of neuro patients there too. So any type of head trauma, any type of gunshot wounds, right? Your motor vehicle accidents where you have your acceleration, deceleration, your traumatic brain injury. So these are most of the patients that we see. Since in surgical trauma, like it sounds, it's a lot of your trauma patients. So your motor vehicle accidents where they have multiple orthopedic fractures, your gunshot wounds to the face, to the abdomen, any type of abdominal surgery, which whether they, for example, had any type of, they embolized or had an embolic event to any type of their arteries that goes to their colon, to their bowels, etc. And they basically made their bowels or their any type of their bowels ischemic. These are the type of patients that we see. So this is a rotation that I'm doing again, and I do have to say that the first time that I did it, I did not like the rotation because I didn't know what I was doing. The first day, I was literally trying to keep my head above water because I didn't know anything. I was unfamiliar with the drains that were coming out. Some of these surgeries I had never heard of because they were so complicated. They connected what? They connected the small bowel to the what to this bowel, or the stomach is connected to this. It was just so complicated. And then what is coming out of their abdomen? They have this drain from this drain, and it's connecting to this drain. I don't know what's going on. And so it was definitely another world. But now that I'm completing it again, I do have to say that I really like this rotation. I really loved surgical trauma because the acuity is so high and you get to work really closely with ortho. And if you work with orthopedics, I mean, those dudes are awesome. I mean, they love their job and they're great. And so I really liked it this second time around. Now that I feel more comfortable with the ventilators, I don't feel like the nurses are pimping me all the time when they have a question and they're asking me a question about their patient. I'm comfortable with interpreting ABGs and what to do on the ventilator if an ABG is abnormal, what to do if a lactate's high, for example, like what are my differential diagnoses, vasopressors, which ones do I use on which patient, right? Norepinephrine versus epinephrine versus vasopressin. When do you add epi to norepinephrine? At what dose? Intubations, I feel more comfortable with intubations. What medications do I use for intubations, right? What type of sedation do I want to use on this patient? Like, do I want to take off the propofol, maybe add some fentanyl? Are they not responding to the propofol? Maybe we can try some ketamine. Also, antibiotics. And given that we're in the COVID world, everything's running out. So Zosyn was one of the things that we used a lot. And unfortunately, it started running out in our hospital, so we needed to use another broad-spectrum antibiotic like cefepime. And so the fact that I got really comfortable with antibiotics just in general to use them, I really like that. Got really comfortable with reading CT abdomen and pelvises, which is something you do a lot in the surgical trauma ICU. And so I feel more comfortable reading these. This was definitely not something I was comfortable the first month, but after you keep looking at them daily, you get really comfortable seeing them. Also, chest x-rays. I mean, PA school, I think they kind of focus a lot on chest x-rays, but once you see them on a daily basis and you've seen the extreme forms of a huge pneumothorax versus like an ARDS patient, and you see these on a daily, you get really comfortable reading them. So I got really comfortable reading also these chest x-rays, abdominal x-rays, also got comfortable placing nasogastric tubes or duo tubes, which is something they don't teach you in PA school. And CT scans, like I said, intubating patients, doing procedures just in general, even though I do have to say that I'm not very good with arterial lines. That's something I still struggle with, but I'm not the only one. I know a lot of people struggle with them because just the vessel's so small. And if the patient is dehydrated, or just your older patients, your vessels are even smaller. So you're having to go through an ultrasound and try to stick a needle through that tiny, tiny vessel. Sometimes it's really hard, and it's really all about just how good you are in finessing the needle with the ultrasound. But central lines are amazing because the vessel is a lot bigger, and so that's what I really like. Comfortable with bronchoscopies now. I think they're very soothing, especially if a patient has, a lot of gunk and you're able to clean that out, and then you get a repeat chest x-ray and their atelectasis improved and they were just mucus plugging, and that's why the patient was desatting oxygen-wise. And then also very comfortable with the ventilator, right? What to do on the ventilator settings, weaning patients off the ventilator. How do you escalate and you go from BiPAP into a ventilator? What's that step? When are you going to take that step in a patient that's crashing, for example? So I just feel more comfortable with all this, which was something I was not comfortable with if you would have asked me a few months ago. I do definitely, like I said, have to work more on my arterial lines. That's one of the procedures that I'm very terrified, and I do have to say I've yet to do a supraclavicular line. Those are usually done blindly, and I've seen residents and fellows do them, and I think I'm just terrified of doing them because I've seen them put patients into arrhythmias where patients have to get cardioverted. So I'm very scared about that. But that's one of the things I do have to learn, because in the neuro ICU, that's all we do. We don't really place any type of line in the neck, especially in your internal jugular vein, because it can actually cause and decrease perfusion to the brain. So the majority of the patients have any type of brain trauma, right? So it's one of the things I do have to work with. And then also I still have to work with more on treating the patient that's actively crashing in front of me and having a good differential diagnosis, because those situations are very, very scary and they're very nerve-wracking. And sometimes it can just blind and fog your thinking. And that's definitely one of the things I have to work with. So that's going to be one of the things I'm going to work with my next month. But I do have to say I feel a lot more comfortable in comparison to the first month when I rotated there. I'm able to come up with a plan. I feel better during presentations and rounds. I'm able to present the patient and actually feel more confident when I'm giving my plan for the patient. So I can definitely see an improvement from when I started to where I am now. And I do have to say that everything I've gone through is just fantastic, and I've learned so much. The other thing I do have to say, though, is that the hours are definitely getting to me. Like I said, I work 6 days a week. I only have 1 day off, and sometimes we work about 10 to 12 hours a day. And so that's really, really exhausting. I miss my family. I rarely get to see my husband, but the good thing is that he's very supportive and very understanding. And that's really important, to have your partner or family member that's really supportive of what you're doing. and I'm almost near that tunnel. I can see it, the light at the end of the tunnel, so I'm almost done with my residency. This is my 7th month. So my 8th month and the rest of my residency is going to be geared toward neurology or neurovascular and neurosurgery, since that's where I'm going to be working at. I'm going to be in the neurovascular ICU and the neurotrauma ICU, so they want me to be very comfortable with reading MRIs. I feel good, and I'm able to, of course, recognize an abnormal MRI, brain MRI versus a normal MRI, and I'm able to look at the ventricles and midline shift and everything, but I need definitely a lot more learning in regards to just identifying the structures on a brain MRI and the different types of brain MRI and how to read them. So that's definitely one of the things that they're going to teach me. I'll be rotating with the radiology department the next month, these next few months upcoming. I'll be with the stroke team. So I'll be going to these patients that come in fresh from a hospital or from the ER and being the first one to evaluate them and see whether, you know, do they need any type of intervention done or not, like what's your stroke scale, etc. And then I'll be in the ORs with neurosurgery with these patients that need, for example, decompressive hemicraniectomies, or need any type of neurosurgical procedure. And then I'll also be with neurointerventional radiology, which is also a different specialty for these patients. So yeah, so I'm really excited. My next rotation is going to be back in the neurovascular ICU. So I'm very excited, and I will definitely tell you how I have grown as a APP. Hopefully this video is motivational for you. Like I said, I highly, highly recommend a post PA, or whether you're a nurse practitioner, residency / fellowship, whether it's in emergency medicine. I know the hospital I work with also has it in cardiac surgery. Highly recommend it. You learn so much, and I can say that I'm very well-rounded versus my fellow colleagues that got trained on the job that only know neuro. I'm very comfortable with cardiac patients. I'm very comfortable with transplant patients, and I know once I finish the residency, I'm definitely going to be picking up shifts in these different specialties so I can keep up my education that I've learned and just be well-rounded in general. Alright guys, I hope this video is helpful, and as always, leave a comment below. I'll try to get back to you as soon as I can, but unfortunately, I'm just so busy all the time with this residency, it's hard to, but I really will try my best. As always, take care, and I'll talk to you guys later. Bye.